Good afternoon and good morning, everyone. Thanks for joining us and welcome to this webinar on using the MetaSense Nociception Index Monitor to help us guide anesthesia dosing in obese patients. I'm Frank Overdijk. I'm an anesthesiology professor and MetaSense's consultant medical director, and I'm based in Charleston, South Carolina. Obesity is a worldwide epidemic. 40% of the United States population is obese. 8% is morbidly obese. And although this is less in Europe and other parts of the world, the prevalence of obesity is increasing. Traditional weight-based or lean-based dosing of opioids and analgesics is outdated and very difficult in patients such as opioid-tolerant patients. We need a monitor that can give us personalized feedback on inadequate analgesia during surgery. We are lucky to have these two clinicians with us who are experienced in using the Knoll monitor in obese patients, and they will share with us their pearls of wisdom. Professor Dr. Jan Muller was a previous head of the Department of Anesthesiology at AC St. Jan Brugge and will continue his work at the University of Ghent in Belgium. He founded the European and International Society of Perioperative Care of the Obese Patient, and he pioneered opioid-free anesthesia to enhance recovery after surgery. His groundbreaking work with sympatholytics has allowed us to improve the blockage of surgical stress throughout personalized dosing based on this monitoring, and you'll see some fabulous examples of that. Dr. Isabel Marcolino is the head of the Institute of Anesthesiology and Intensive Care Medicine at Spital Limmattal, the largest center for bariatric surgery in Switzerland. She is an advocate of delivering personalized care, PC squared approach, and is an enthusiast of opioid-free and multimodal analgesia regimes. Just to remind everyone that this webinar is about taking care of our obese patients using the nociception monitoring and is not endorsing or advocating opioid-free anesthesia or specific anesthesia techniques. I'm going to spend the first 5 minutes introducing this monitor to those who are new to the concept of nociception monitoring and this device. Next slide, please, Joelle. As anesthesiologists, we are responsible to provide these three components of an anesthetic. Since the 1970s, we've had an objective monitor of muscle relaxation, the Trainer 4 monitor, which now is vastly improved and now we have the quantitative monitoring of neuromuscular blockade. In the 1990s, we got our first depth of anesthesia monitor, the BIS, and we now have several technologies intended to measure the depth of anesthesia. We've got the SedLine, the Narcotrend, etc. But we've never had an objective monitor of guiding the dosing of analgesics intraoperatively. We rely on surrogate vital signs, such as heart rate and blood pressure, but these are not necessarily indicative of pain or nociception in patients with essential hypertension or beta blockers. Next slide, please. So pain is defined as a subjective sensation and can only be given by the patient. So under anesthesia, the patient's unconscious and can't give us their pain levels. Thus, the appropriate term is nociception. Nociception during surgery is manifest by the activation of the sympathetic nervous system. Blood pressure and heart rate increase, pupils dilate, skin starts to sweat, etc. Currently, we anesthesiologists look primarily at blood pressure and heart rate as surrogate measures of nociception and to guide our analgesics, which are typically opioids. But we can see here that the systems that this Knoll monitor monitors are basically the vascular, cardiovascular system, as well as the skin. Next slide, please. So the Knoll uses a finger probe to sense changes in the blood vessels, the heart, and the skin to quantify the amount of nociception. Here is a transducer, a sensor in a cradle attached to the finger. The sensor measures the plethysmograph, or the PPG, which we're familiar with because it's the same signal from which we derive the pulse oxygen saturation. But this probe does not measure oxygen saturation. It uses a single frequency to measure the pleth amplitude, the heart rate, and the skin conductance to quantify nociception. And with these metrics, their variability, and their derivatives, a machine learning algorithm calculates the nociception index or the null index. It senses temperature and movements, but only to establish operational limits for the monitor. It's not part of the null index determination. Next slide. So the null index scale goes from 0, which is no nociception, to 100, extreme nociception, with any null value greater than 25 sustained for at least a minute, implying that the nociception anti-nociception balance, the NAN-B as we call it, is inadequate for the stimulus, and the provider should consider giving analgesia. It's not a linear scale, which means that the null index of 50 is not twice the nociception of a null index of 25. The index is simply an ordinal scale, which means the higher number is likely greater stimulus than a lower number. And as with any continuous patterns, whenever you monitor something continuously, it's the patterns and trends that are really most important. I'm not going to get into the specific algorithm on this talk, because we have a lot of interesting clinical aspects to discuss with our panel as it relates to taking care of obese patients. Next slide, please. We are going to ask you, the audience, some questions regarding nociception monitoring, which we will discuss at the end of the panel discussion, time permitting. You can also add your questions to the Q&A box on Zoom, and they will get answered, hopefully during the webinar, but maybe afterwards as well. Now let's start and ask our panel some questions. Enough of me. The first question was pretty much answered in the introduction I gave for our two speakers. Next slide, please, Joella. And now we can take the poll down. Those are simple questions. Thank you. So, welcome, Dr. Marcolino and Dr. Mulier. Let me ask you, when planning an anesthetic for a patient with morbid obesity, are you a proponent of opioid-free anesthesia? Do you prefer opioid-sparing, multimodal techniques? And does it depend on the type of surgery? Now, based on the introduction, I think you're both big fans of OFA and multimodal, but let me ask you then the second part of the question, type of surgery, how do you make that choice? Marcolino, Dr. Marcolino, let's start with you.
Thank you very much. Hi, everybody. Well, I have to say for bariatric surgery specifically, I'm fully 100% for OFA, because in these patients for this type of surgery, it has big advantages. It enhances their recovery. There's less nausea. There's early mobilization. If we have obese patients, for example, undergoing other surgeries like orthopedic surgeries, I would prefer going to multimodal regimen, also including regional anesthesia techniques, which can provide great benefit to these patients. In general, for all other patients, we have multimodal anesthetic regimen, also including the obese patients. But what I say is, if you, within choosing your panel of multimodal anesthesia, it's important in the obese patient to always opt for less opioids. Even if you give opioids, try to give less opioids than you would do with your same protocol in normal patients.
Excellent, thank you. Dr. Mulier, welcome, and your opinion on this.
Yes, I have no conflicts of interest regarding this subject, and I fully agree with what Isabel was just telling. She is also a wonderful anesthesiologist using opioid-free anesthesia. I was recently also visiting her department, lovely. Indeed, the patient with obesity, as we should say today, is indeed a difficult patient, and where the opioids really create problems. And Isabel was already telling, I would just add that obstructive breathing, even in patients without OSAs, will increase if you use opioids. So that's for me also an important reason to trying to avoid the opioids. And even very low doses of opioids still have some side effects. So going almost to zero intraoperative, what is opioid-free, really makes sense. And you can say, well, can argue what does it matter, because after the operation you might still need an opioid as part of the analgesia treatment, and that's true certainly for a type of surgery that is quite invasive, like a thoracotomy or a full laparotomy. Nevertheless, when you don't use any opioids intraoperative, the doses of opioids you will require are most of the time significantly less postoperative.
So you are both opioid minimalists, and there's been literature recently saying we will never get rid of opioids, but it's be very interesting to hear how you deal with it intraoperatively in that setting. Let's go to the second part of this. Do you always use NOL together with a processed EEG monitor and to measure depth of anesthesia? Go ahead, Joelle. And I think Isabel's going to start us off.
Of course. We have seen this slide before in the introduction, Frank, with a different point of view, how we measure the so-called triad of anesthesia. And I just put here the agents we give to achieve the goals in all three aspects of anesthesia, like muscle relaxation, hypnosis, and the so-called analgesia or nociception, or maybe sympathetic depression. I think it's very important that we apply these concepts to all our patients, not only the obese, throughout anesthesia, but that we also measure what we are doing and specifically measure what we are doing. So I'm quite an advocate of using the NMB monitoring, the hypnosis monitoring, and the analgesic monitoring. And actually, I have to admit, and Jan will have a talk on this, that the idea of this triad of anesthesia is not quite new. It hasn't come up in the recent years. It's actually quite an old concept.
Next slide.
Mm-hmm.
Well, yes, and I would like to continue on this aspect, because the concept, the triad of the narcosis, analgesia, relaxation, is given by Cecil Gray in 1946, when he found out that adding a neuromuscular block allows to go to a less deep general anesthesia. At that time, thiopentol, halothane, and so on really had a lot of side effects. So by combining with neuromuscular blockers, you were able to go for light anesthesia. And that's where he brought up this model. However, in 59, and he published that in 60, just before the synthetic opioids came on the market, like fentanyl, he was warning, and he republished, and he said, look, you shouldn't be talking about analgesia during general anesthesia when a patient is asleep, but instead we should be talking about reflex depression, because what we need to do during general anesthesia, besides having a patient asleep and neuromuscular blocked, is having actually no reflexes of the sympathetic system. And you can achieve that by opioids, but there are other ways too. And at that time, local regional anesthesia started also to being quite important to get the sympathetic system blocked. We go for the next slide. And in the next slide, I'll show you a little bit further, because Cecil Gray started in a period where medicine was one dose fits all. And it was one drug, like the inhalation anesthesia of ether chloroform, doing everything. And we all had an average that every patient required. We moved away, and Cecil Gray started that by using 3 drugs, each drug for one effect. And moreover, we started today to go into personalized prediction. And that means based on the age and the weight, certainly of the patient with morbid obesity, where we choose also to some drugs to based on lean body weight instead of on total body weight, based on gender and genetics and so on, we try to predict very accurate what dose we will require for each of these effects. And that's what we still do in a lot of cases today. That's why we also need these PK models and TCI models, where we predict exactly what dose, what plasma concentrations we will achieve with propofol, with remifentanil, and so on. But the future really is keeping this prediction, but going further and measuring effectively and measuring the effect in each person and adapting. It means we can measure now the depth of neuromuscular block. We can measure the depth of hypnosis, but we can also measure, and that's why we're talking today, the nociception. And by measuring these 3 independent effects, we are able to adapt further the dose. And what we see is that each patient doesn't require the same dose. So the average dose in publications is not the right dose for your patient in this situation. The type of surgery is also different from case to case. And moreover, what you will see is that during surgery, the amount of stress coming from the surgeon is not equal in the beginning as in the end of the procedure. And so that's where it is time to personalize the anesthesia the whole case through. And the only possibility is to measure what is going on, measure the depth of hypnosis, measure the depth of muscle relaxation, and measure the depth of sympathetic depression. We might still miss some other monitors like metabolic suppression or like the inflammatory system, but some of them are linked, like the inflammation and the immune system is a little bit linked to the sympathetic system. We don't have time to go in detail on that, but what we will show is that maybe we have to go very deep in blocking the sympathetic system, because by that we are also avoiding an activation of the inflammatory system. Next slide.
Thank you, Professor Merlier. Sympathetic lysis is really what you're talking about, and we'll get to some great examples of this. So next question, how does null monitoring improve your decision-making when it comes to dosing the analgesics? Do you have a strict protocol when it comes to the threshold of 25, or use subjective and look at trends and patterns? Next slide.
So first of all, when using the null, I would like to show the audience what might go missing if you don't use a nociception monitor. This is the performance of a bariatric redo operation on a female. She was born in 77, 64 kilograms, 157. So she already is not quite obese again, but she is treated to the OFA regimen. And what you can see throughout the operation, I didn't show you the EEG or the hemodynamics, but I can tell you the process EEG was within range and the hemodynamics were stable. That there are a lot of events which cause sympathetic stress, which cause a noxious stimulus or nociceptive stimulus, you might call it. You can't see when using conventional parameters. As I said, we had the introduction and the intubation, and we had a stable BIS without alpha dropout, and we still had a huge nociceptive stimulus performing the intubation. And when you have like surgical actions, when looking at conventional surgical procedures won't reckon to be this noxious, we can see that something small like placing a trocar could do a huge amplitude gain when seeing on a nociception monitor, which is considered over time for more than 2 minutes be really a noxious stimulus, as well as the stapling, even when using new devices, which like gentle performance is using noxious stimuli, and you should cover them to have less inflammation, less activation of the sympathetic nervous system. And if you don't measure them, you will miss them. I also want to show you that there might be some small interferences, of course, in the monitoring when using sympathoactivating drugs like ephedrine, but as you can see in comparison to noxious stimuli, this is just short, very brief reaction of the sympathetic nervous system. And when you have on the right-hand side, you have the evaluation of the case of times where you are in the so-called range. The green range is the range for the nociception monitoring from 10 to 25 below. The white one is below 10, and the red one is where you have noxious stimuli for over 25. So what I want to tell you, it's definitely worth not looking only on the numbers, is looking on trends and patterns, is looking on what is going on. And I'm a strong advocate, and I call it the white should be the new green, or green and white should be the new green, because I think as long as you have a stable situation, there can't be enough sympathicolysis. We will talk about this later. Next slide, please.
Hold on, let me ask one quick question. So Dr. Marcolino, you mentioned something important. We want to be below 25, but you have a lot of white on that pie chart. Were you trying to make some of that white more green? And I think your answer was no, I like it below that because I'm really blunting the sympathetic responses that we want to do. So I'm okay with that. Is that correct?
I'm happy with that, to be honest. Yeah. I'm very happy. That's what I want to achieve, as long as I don't have any side effects of the sympathetic block. This is achievable when using modern drugs like dexmedetomidine, and I would love the white to be the new green. Yeah.
Yeah. So maybe lighter green with smiley faces. So okay, so that's good, and we don't have that much red. Okay, next slide.
Yeah. What I wanted to emphasize on that slide again, you have the same range of time of 1 hour, like a comparison between the process EEG monitoring and the null monitoring. And there are people who claim that when you are an expert in process EEG and you have noxious stimuli as detected by a nociception monitoring, that you can also identify them using the process EEG, where you can see definitely an alpha dropout, which is this this is the fallout, as I showed on the arrow on the left-hand side there. You have a noxious stimulus, which clearly correlates with an alpha dropout in the EEG. So it's on the right-hand side on both pictures. You can see it marked by the arrows. But as you can see in the null trend from beforehand over the last 1.5 hours, there were significant nociception stimuli, which weren't detected at all by process EEG. And so this is important to have the complete ride monitor, as mentioned before, and to have a close look on what is going on trends and patterns and getting the whole picture.
Great. Next slide, please. So the correlate, really important to have your EEG and such. Yes, definitely.
Yes, and indeed, well, we all have learned to look to the hemodynamics. And on the left, you see clearly the hemodynamics with a saturation that is nice, the blood pressure that is just a little bit more on the low end, but it is regarding also to the surgical request at that moment in this procedure. But the heart rate is 62. So there seems to be no surgical stress at all, at least in the hemodynamics. But when we look here to the nociceptive monitor, we see that there was a dramatic nociceptive reaction of the patient. The null went up to 75%, quite high levels. And that means that we were not fully aware of it. If you also look to the trends of the heart rate, it was not visible. And so you are missing a lot of these stressful moments if you look only to the values of the hemodynamics, also to the values of the BIS. The BIS, as you can see here, is also quite stable, rather at the deep level of 40. It should be even closer to the 60. And so what we have been doing in this case, you see here, because it was already a few minutes, and when we got levels that high, before it was almost zero, we have been giving an extra dose of 20 micrograms of dexmedetomidine. Now, dexmedetomidine is an alpha-2 agonist, is very effective in blocking the sympathetic system, although it takes a little bit more time. And that's sometimes a little bit a problem, while like remifentanil is much faster in its effect. And you see here that, but even after a few minutes we went down, we still had some spikes up and down, up and down. So it can be a question, was this dose sufficient? Shouldn't we have been giving more? But finally, after 15, 20 minutes, we came back all the way to zero. A short moment of having some stress is not a problem at all. It all depends also on the patient and the frailty of the patient. If you have a patient with a frail cardiovascular system, is very limited in his reserves, I would really keep the sympathetic block maximum as possible. A young guy, well, he can sustain short moments of having that effect. The same is also true if you will give some ephedrine, less with only vasoconstrictors, you will see some sympathetic reactions also on the monitor. And that's real true because we are stimulating at that moment the sympathetic system in order to get the blood pressure up. So having the tool also verify that the extra dose you have been giving is sufficient or not, or requires an extra dose. Next slide.
Yeah.
And by that, I would come back a little bit to the different approaches we have been using over time to block the sympathetic reactions effectively. We can say indeed, if we go back to what Cecil Gray, until 45, there was only high dose of inhalation possible. And we assuming that with very high dose of inhalation, the sympathetic stress was sufficiently blocked. Although this was not absolutely true, we had many problems because we had one drug with many side effects. became with balances with the neuromuscular block that allows to go to a lower dose of the inhalation anesthetics, but then the problem of stent got even worse and more dramatically. And that's where some remarks came on Cecil Gray approach, and where he indeed came up with the idea we do not have only the patient to sleep, but we should also put the emphasis on the reflexes. From 64, when the synthetic opioids came available, and that started with the fentanyl, we had already the morphine and other drugs, but they had many side effects. Suddenly, we were able to block the sympathetic stress much better by giving higher and higher doses. And we assumed that the side effects were minor. Can I give to the next slide again, because we seem to be brushing up. So next slide. Yeah, and so we had what came with the opioids, we were able to go to much higher doses, but we had side effects of the opioids. And it took up to the 90s till we realized that this was not the ideal approach. We got at that time also better hypnotics, like the propofol, also the inhalation with sevoflurane was better than the halothane. But still, and it was Kellett, Henry Kellett even wrote at that time that stress-free anesthesia might be a myth. It seems to be impossible to reach. Even whatever high dose of opioids you are given, you're never fully there. On top of that, the opioids at these high doses really start giving a lot of side effects that we were really worrying about, being patients with nausea, vomiting, respiratory depression, obstructive breathing, chronic opioid use thereafter, opioid addiction, and so on. And it's also the time where we start using other non-opioid drugs as analgesics postoperatively in the multimodal analgesia in an effort to reduce the opioids. But by having still using very high dose of opioids intraoperative, it was quite difficult to get rid of the opioids postoperative and all its side effects. And that's where we have been start searching from 2010 off. Are we not able to block the sympathetic system better with non-opioids? And one of the options is indeed also local regional anesthesia that is quite effective in blocking the sympathetic stress directly going to the brain. It's not effective in blocking the inflammatory actions, and that's where we have to focus on in the future also. To get rid of that. But so blocking sympathetic system, local regional, but you can do that today also with non-opioids like the alpha-2 agonists, typically the clonidine, the dexmedetomidine, but also drugs that are used for local region like lidocaine has also some sympathetic blocking effects. We also have the ketamine, the magnesium. They all have some side effects. And that's where we realize that if we start also working multimodal intraoperative, not only postoperative, by combining these drugs, we will be able to use these drugs at a lower dose. And with this lower dose, we will have able to have less side effects because also the lidocaine, the ketamine will have hallucinations, the magnesium will have muscle weakness, hypotension, as also the alpha-2 agonists, if you have been giving them in high dose only. And so that's the movement away from the opioids, partly for a while, and going to multimodal approach, intraoperative and postoperative, with almost no need for opioids intraoperative, still a need for opioids postoperative, but that's not anesthesia anymore, that's analgesia. And in this regard, it is really helpful to have also monitors to guide you, because you might end up with overdosing. So initially, when I started opioid-free anesthesia in 2010, around that time, I didn't have any good monitor of sympathetic stress. And it means that I probably was also overdosing my dexmedetomidine with more hypotension, bradycardia, postoperative. And today we are able to go really low down and just give the dose that each patient will need. And for that, we will have some examples showing that.
Next slide, please.
Yeah, sorry.
Yeah, this is just on emphasizing what Thierry Jan was explaining very beautifully, and just want to show you again my favorite with the new green, because this is two examples of direct sympathicolysis of either using an anesthesia based on sympatholytic alpha-2 agonist, dexmedetomidine in this case, which is the upper panel showing a null around 10, or actually using what we also advocate of using if obese patients or diabetic patients undergo open laparotomy, for example, using an epidural, or using we sometimes in the ARES protocol use a spinal combined with the ARES protocol, where you have total sympatholysis due to the block. And still you can see, even with a total block, there are several stimuli which can come through. But hearing all about the advantages of sympatholysis, we would truly advocate of choosing like drugs or anesthesia techniques like epidural or spinal to have as much sympatholysis as possible. Of course, always looking at the side effects, which were already nicely explained.
Yeah, that's very nice. So if you were to compare this to a non-null, previous slide, please, Joella. Dr. Marcolino, if you compare this to not using null, you would see a lot more red. We actually have, the company has in true control trials but you would, before you had the null monitor, you had a lot more, you would have had a lot more red if you were blinded to the null.
Exactly, I would have a lot more of red. And on the other hand side, I mean, if you have the so-called as you pointed out, the null value is not linear, but still it's the ordeal number. So we suppose 50 is a much higher NOx stimulus than 25, even it not being a linear scale. And for example, if you perform anesthesia for an open rectal resection, you have an epidural for it, you have the situation that the sacral segments might not be covered by your epidural, and you do a top up using opioids. And so what if you don't have a null monitor, you might overdose it because you just think that you might not have a coverage. I mean, there are some rare cases where the epidural even covers these segments, or you think that you need more coverage, or you apply too much opioids, so you can't actually tailor your dosing to the patient's need. And so you also might have too much white, but it's not the good white, because it's a sympatholysis which is not provoked by direct sympatholytic acting drugs, but also having a lot of side effects, for example, as using opioids. So it helps you actually to get the dose really tailored to the individual patient and individual situation. If you don't have these, you might have some white, which is bad white, not a nice light green white we were talking about,
right.
or you have more red, as was shown in studies before. Yeah.
If I can have both of you comment, opioid tolerant patients, this not dosing in the dark make a difference to you?
Well,
go ahead.
Sorry, you can go first, Isabel.
No, go ahead, Jan.
Yeah, go first, Jan.
Yeah.
It's fine.
Well, indeed, patients that are opioid addicted or tolerant and require much higher doses, it's extremely difficult to be aware what dose of opioids you will need to block the sympathetic system. Just to remark, the tolerance for the opioids is most on the analgesic property and almost never on the respiratory depression or on the nausea vomiting. So that means that you will need to increase the dose to block the sympathetic system and to have again analgesia, but you will get in more troubles afterwards in having the patient stop breathing and being dramatically nauseous and vomiting. That's why this is even the group where opioid-free anesthesia, or at least adding additives next to opioids, is really ideal to work. But again, if you still use opioids, or you use a lower dose of opioids, or you go for opioid-free, these patients, you will need a nociceptive monitor, essential to be aware where you are. Otherwise, you might end up with a patient waking up and crying of pain of all the troubles, even if the hemodynamics didn't show that. And that's why most of the time in the past, we really have been using huge doses of opioids in this group of patients without any monitor, just to be sure that we were giving enough.
Yeah,
Dr.
this was, I actually was also thinking about. Actually, I mean, it sounds a little bit paradoxical, but you can do opioid overdosing, large opioid overdosing, just on calculating the patient's need. Even you have all these calculators for the equivalent, and you add on for your procedures. There will be single opioid dependent patient or drug dependent patient where you, when measuring binaural, are hugely overdosing your calculated anesthesia regimen. So I strongly advise in this patient, because some of them are not only opioid depending, they have a whole, I call it cocktail on different drugs, and you can, which have different stimulation, not only on the sympathetic system, but also on other neurotransmitters, and with like additives, like NMDA receptor blocking drugs, magnesium. You can also calculate more the actions and get them with the minimal dose of each agent, a perfect anesthetic regimen throughout the operation. Yeah, and this is very important, because these are patients where you really, really, really need to try it.
Great. Next slide, please, Joella. So what was the learning curve? Do you know how many cases where you're confident with using it to dose analgesia? Isabel?
Actually, what about the learning curve? I mean, it depends where you start from and what is your current situation. What I truly would recommend is to start with standardized protocol. If you have operations, does it mean personally to you as an anesthetist or for your whole department, as in my case? Just don't think, oh, this is the noise, it's very interesting, let's put it in orthopedics, then use it in obese patients, have it with multimodal regimen. I think just pick one operation. I actually would recommend in the beginning, take a simple one and just observe. Observe, do your normal standardized protocol and observe. Just see, try to correlate what you are seeing, going to the literature, seeing if other ones have the same findings, getting ideas. And then maybe you extend your approach to, like the patient population, use it on the same operation, the same standardized protocol, but you might include some patients which belong to so-called risk groups, let's say obese patients or dependent patients, or also frail patients we have already talked about, and just observe. And then you get a good base what you are observing. And then from that, once again, try to alter little steps. Just say, if I give, for example, what we started when we saw on the obese patients bariatric surgery, that it was this huge reaction to the skin incision and the trocar placement. So what we implemented, I mean, we use lidocaine, we use ketamine, we use dexmedetomidine. So I asked my staff, and one wanted to use a ketamine bolus, the other one wanted to use a propofol bolus, the next one wanted to use a dexmedetomidine bolus. I mean, like this, it's not working. So we agreed as a team on, let's just a few minutes before starting operation, give another dexmedetomidine bolus, and then see in the null monitoring if we can, this spike I was showing you before, if it gets less, or maybe we just have to adjust the dosing. So this is a step-by-step approach. I hugely recommend to everyone. I don't know what's your experience, Jan, on that.
Jan has that's great. That's great information for the audience. Jan has a small video that we're going to play. Next slide, please. And Jan, if you can, it's 2.5 minutes long, so we'd like to shorten this up. If we'll start it up and you just narrate it. And if you say,
well, great. So this is just a case, and you can start a video, because you need to use the monitor sufficiently every day to get experience, not just for a difficult case. And this is a simple case, and you saw that there was a dramatic reaction on the null. So, and we decided, because it took already several minutes, to give here again, because this is under opioid-free, an extra bolus of 5 milliliters of dexmedetomidine, 20 micrograms, because it's 4 micrograms per milliliter. And we will see, we see here the dose, it's 4 micrograms per milliliter, and we have been giving 5 cc. And you see the values are really high, 52. So it is really a need to block these effects. You can also ask the surgeon to reduce or stop for a while. That might be also a solution, but most surgeons will say, well, we keep going. And you see already how it is dropping. This is a spinal procedure, so the surgeon is still going on. As you can see, the hemodynamics are stable. From the hemodynamics, again, you wouldn't be aware that this was happening. And you can see here, in a few minutes, we are already coming down. We have here the hemodynamics, again, here, nice, stable. So no reason based on that, but the monitoring is telling. So again, on the previous question, and I can answer that also, you should start and doing it using the monitor regular. And do not start in, like Isabel was saying, in the complicated, difficult cases, in a frail patient, a patient of 80 or 90 years old. It's lovely to have it there, but you will not train it there. Also not in children or small babies. That's also too early to get the acceptance. And also try to have initially a kind of procedures that are equally, so you can compare and learn doing like a group of cholecystectomies or a group of total knees or other procedure. And it allows you to adapt and to learn initially without changing anything in your basic protocol. But if you see repetitive that the induction is still too much stress, or that on the moment of the incision or other moments when the surgeon is going through the skin again, you will see again a lot of reactions, then you will say, maybe I can adapt and change. And so after 20 or 50 cases, seeing that, you will change your protocol, adapt it. And from then off, you learn how to adapt. If you start then with other procedures, if you start with other groups of patients, again, start with your protocol first and slowly adapt according to that. So that's an important aspect. And once you have the expertise, and it takes even several years before you get full experience, then you even will love it when you get a very difficult case where you're absolutely sure that it will be difficult just on prediction to know where you are. And that can be a patient who is addicted to the opioids. It can be a patient that is always having a dramatic sympathetic reactions. It could be patients that have those Raynaud phenomena or other disease situations where sympathetic system is not reacting as in a normal case, or even like a pheochromocytome I was doing recently. And that's really lovely in such a situation to have a monitor measuring the sympathetic system, but you will need sufficient experience before relying on it.
Yeah, that's an impressive, good video. Great suggestions. We're gonna go, since you've been using a null monitor, what did you change intraoperatively? And you've sort of answered this question. So let's go to the next question, which what are the main outcome improvements that you see when using null? Quality metrics. You talked about sympathetic lysis. There are studies that show decreased stress responses as measured by cortisol and such after null guided anesthesia. Certainly, there's studies that show there's decreased PACU pain to some degree, and most importantly, that there's decreased severe pain. The incidence of severe pain in those patients, what you were talking to, Jan, the patient who's screaming initially, you had no idea. You've used your weight-based dosing, and all of a sudden, this patient acts outside of the curve. Personalized anesthesia. But let's talk about a little bit about this, and we have a great next slide that Dr. Marcolino is speaking to.
Well, actually, I would like to point out a little bit, and also in the context what is the aim of anesthesia, what is anesthesia actually about, and it's actually what is in the center of all our actions. It's the patient, it's so-called patient-centered or personalized care or anesthesia. And as you said, then, or as we have shown in several examples so far, the null in the aspect of precision delivery of our different types of anesthetics is one add-on which helps us to calculate the nociception or the noxious part of surgical procedures, and we can precisely deliver in routine patient groups, but also with some experience in patient groups at risk, which were mentioned before, a precision delivery of anesthesia. And we have all those outcomes shown in several studies you mentioned before, Frank, like less side effects because you are less dosing of opioids, you have less nausea, less vomiting, less PACU pain, less exacerbation of pain, you have a lot of you know what is under investigation, less sympathetic stress response. You might have less inflammation, less stimulation of the immune system. But what I also think, and sometimes we, so far we haven't done it on a structured way, but about to implement it, the so-called the PROMs, the patient-reported outcomes. But sometimes, even if you don't have systematically, you sometimes get emails or you get something on the feedback from the hospital. And what we noticed when in a lot of cases where we have this multimodal regimen and also the precise regimen, that we get emails from patients that's saying, yeah, we had anesthesia and I never felt so fit. We had a colleague of ours who was operated at our hospital. It's a general practitioner. And he said, can you imagine, Dr. Marcolino, I had a hernia repair this morning. And I mean, of course, I have to rest, but at 3 p.m., I was in my office sitting back, taking care of some patient charts. And this is what you want to hear. And as anesthesia or medicine in general should also include more patient-reported outcome measures. I think in a systematic review, we should get more of this to get even better, and also to give a feedback to help to refine our measuring systems for delivery also on patient-reported outcomes. And this, to me, is very crucial, this patient-centered medicine.
Yeah, that's great. We're going to wrap up my questions in the next 5 minutes. Please get on the Q&A session or on the chat and ask Professor Moliere, Professor Marcolino questions specifically they can answer. We'll have some time for that. At that point, we'll also put the survey up again because we want to be able to see your answers. Previous slide. Are we on this slide? Yeah, we are. Yeah, go ahead. Go ahead, Joel. You are correct.
Yeah, okay.
If you have any questions, ask them now. Go ahead, Jan.
Yes, all right. And I fully agree with Dr. Isabel Marcolini what was telling us. Absolutely, we have to look to more than just only the pain after the operation, the full well-being of the patient. And we will not have that if you really overdose too much or underdose at all. But again, I would show you again 2 examples of dramatic difference between, because we know what the average is, but this here is a patient with obesity, but not because the obesity undergoing here laparoscopic surgery. And we were measuring continuously, and so still moments of stress going, and then a percentage above 25, requiring each time extra doses of dexamethasone. There was a continuous infusion running, but on top of that, we have been giving each time 10 to 20 micron. And as you find out here at the end of the procedure, and it was only a short procedure, we needed almost 1.1 micron per kilogram lean body weight of dexmedetomidine to get the stress blocked actually sufficiently. And that's an important aspect. Every patient is so different. It may be also due to the surgeon going to the skin several times, dilating the skin also. But if we were not aware, we would probably have underdosed our anesthetics in this specific patient. And we go just to the next patient. The next patient is a procedure that is even 3 hours length. Next slide. 3 hours length. And is a little bit older, and I was a little precocious, so I gave only 10 micrograms of dexamethasone before the induction and 5 micrograms at the intubation phase. And I didn't start any infusion pump, but because I found immediately that the null was grounds to 0, there was no stress. And actually, this patient stayed with 15 micrograms of dexamethasone for 3 hours with a null trend, as you can see, quite continuously in the white zone below the 10. So without the monitor, I would currently overdose this patient. I would have given him a lot of opioids, but there was absolutely no need at all for it. And again, so these values are not always predictable based on the age, the procedure, and anything else. And so with this monitor, on one side, you're able to reduce the dose dramatically or give a lot more as required. And both of these patients have been waking up very nicely without any pain initially, but also in a very good well-being, because besides the pain, we also want to, because the sympathetic system is more than only pain, it's also the immunologic system and the inflammatory reactions. And so what we figure out now today is that if we allow the sympathetic system to be overstressed, overreacted, we also are exhausting the immunologic system. And it means that if this system is exhausted during the procedure, for the next days, sometimes weeks, we might even have an immunologic system that is less active because it's all consumed already. And that's when we need the repair, when we need the defense against microorganisms that might have invaded and so on. And therefore, it is so important to keep that inflammatory system, immune system active and not reacting while it does not need, not start shooting when there is no need to shoot yet, but keep its reserve for the days after. And therefore, I think it's just more important than only having a patient waking up pain-free. It's having a patient that is waking up stress-free. Next slide.
Yeah. Actually, I wanted to add on that's that it's important also now to coming back a little bit to the population we were talking before in the obese patient. I mean, patients with chronic inflammation, they have alteration in their immune system, not yet quite all defined. And I think this is also why it is important to block those responses in obese patients specifically. Yeah.
Yeah, great points. Last question from me anyway. Regional anesthesia, peripheral nerve blocks, things like that. We all feel so much better when we see that the heart rate and blood pressure doesn't go up to surgical stimulation, but that's a very primitive indicator. How does the null monitor help you assess the adequacy of your regional block or peripheral nerve block?
Well, I think it's interesting because you can actually measure if your block is working. You have a direct feedback. It could also be a feedback on yourself. It could also be very interesting in having an objective feedback for trainees, yeah, or if we are teaching to younger unexperienced doctors, so that they have a direct objective feedback why their block might not be sufficient or might be sufficient. And but I think what is more interesting is sometimes we perform combined anesthesia, adrenal and regional, and we have blocks where we know from our anatomy that in individual patients or in all patients, there might also only be a partial coverage of the block. And then we need the so-called top-up. And as I was talking before about the example of the open rectum surgery, where you need the top-up for the very deep sacral segments, you might overdose and you might not have any measurement for a correct dosing or a correct top-up, or even sometimes if a regional anesthesia is not working, we have also the option that our surgery colleagues do top-ups on local infiltrations, and there the null could give us a good feedback if they are successful, or if it need more. Yeah. This is why I think it's a very good add-on, and it's also very useful in orthopedic surgery or in trauma surgery, and not only due to the patients which we are treating there, which are at risk, but also like a technical surveillance of what we are doing.
Great. Before you answer, Jan, let's, Joella, can you put the survey up again so folks can continue responding to those questions? And Professor Molier, go ahead. Regional anesthesia, how does it help?
Well, I fully agree, but we don't, or at least I have not enough experience yet in evaluating the impact of a combination of local regional anesthesia, general anesthesia, while monitoring the effect. And it is clear that if your local regional is not working properly, you will see that on your stress monitor, on the sympathetic system. And if you have like an option to continue like with an epidural, it would be great, because many of us, when we combine epidural with general anesthesia, like for thoracic surgery, frequently we are also overdosing a little bit the epidurals and having them patients hypotensive the whole procedure along while there was no need for it. So with the monitor, you allow to dose titrate a little bit better and avoid this extremely high dosing from the start off. At the same time, and that's what we're also finding out, is that a local regional block alone is not enough to block also the enormous cytokine release on the place of the surgery. And that's why we, even with a local regional block working very well, we might still need some blocking of the general sympathetic system next to the local regional. And that's what the null monitor will be telling also. So it could not only be that your block is insufficient or not properly working, it could be also that the general action and effect of the trauma induced by surgery or by the trauma is so severe that we will need also more systemic suppression to avoid that. And that's why this monitoring really is great in showing both effects at the same time.
Good, great answer. We have a question from the audience. Do you use beta blockers and antihypertensives in case of insufficient sympathetic block and tachycardia or hypertension?
Well, it's a good question. And there is nothing wrong in adding also a beta blocker if there is insufficient, because some of these beta blockers are very fast and immediately in reaction. But I would say in the past, when we had no null monitoring, we were afraid in doing so because we were not aware if we had sufficiently blocked the rest of the sympathetic system. And today, with a null monitoring or another nociceptive monitor, we are aware if we should add other drugs next to this beta blocker. So if a sudden hypertensive reaction or tachycardia reaction happens, my option is sometimes also to take a beta blocker or an antihypertensive immediately to get the blood pressure down. And if there is no reaction at all, what could be as a reflex reaction, pure without any dramatic sympathetic action, I would not give other drugs to block the sympathetic system because it could be tachycardia, heart rate, even with no hypotension or hypovolemia, requiring an action not just by sympathicolytic drugs. And again, you should use it every day, every case, and so you will learn what is happening and differentiate between isolated reaction of the hemodynamic system and general reactions of the sympathetic system.
Yeah, I think this is very important to emphasize. If you have good coverage on the blockage of the sympathetic system and you have reactions in the let's say, the easiest outcome to see is the cardiovascular side, where you have instability, you have to treat hemodynamics differently. I mean, having a triad of anesthesia, monitoring everything doesn't mean that you don't react to the other parameters. Of course, the cardiopulmonary stability dedicated to this organ system is equally important, yeah. What might, in this case, it's not quite related to a question, might be interesting for the audience, because sometimes we get the question if the chronic use of beta blockers does have any influence on the null monitoring. There is to say there are some publications which nicely show, because we didn't talk about in the beginning, the null monitoring adapts to the personalized patient. Is a huge database in the background, finding the ideal patient which fits the actual patient. And so a beta blocker use beforehand or chronic beta blocker use is considered a chronic specific patient condition and doesn't interfere with accuracy of the measurement, just to add on with this question.
Wow, yeah, that's a great point as well. We have a couple of minutes left. I'm going to ask you each for a 30-second answer. Could you go back without using this monitor? How hard would you fight if someone came into the OR and wanted to take this monitor away from you to get the same results in these kind of patients, in patients that have all these issues where you do your sympathetic lysis?
Well, I would fight quite hard, but of course I've already learned a lot from the monitor, so I might, even without a monitor, to be honest, treat the patients better than I treated them before. But I'm very eager and very enthusiastic, so I always want to learn a lot and to do better. And if you took away the monitor from me, I couldn't do so. So it's really hard find for it. But I have to say, even not using the monitor, and I can't use it in any cases because I don't have one in any single operation room, unfortunately. I would treat patients better than before the whole nociception experience.
And as you said, every patient is different, personalized.
Yeah.
So
exactly, yeah.
even though you may have learned some protocols or some things to do with your different agents, every patient's still unpredictable and different in that sense.
Exactly,
So,
I would fight very hard.
30 seconds, yeah.
Yeah, 30 seconds. Well, fully agree. And I wouldn't go back to the time that we had no carbon CO2 measurement, that we had no saturation measurement. Indeed, and that looks strange, but I was started giving anesthesia when there was no saturation, no CO2, whatever. I'm fighting to get, and people who might know me, that in the morning frequently, because not every OR room is equipped, sadly, with these monitors, that they might have seen me early in the morning always running around with one of these tools, setting it up, having sufficient devices. Certainly when you have a special case and a special patient asking to get less troubles, less problems with even postoperative confusion and delirium, I really need this tool to be sure to be able to deliver the top quality of anesthesia, not just the regular average anesthesia as we have been doing in the past. So yes, I wouldn't work without any more.
Well, you two have been fantastic panelists. Your experience in taking care of obese patients with these opioid-sparing techniques is unparalleled. Thank you so much. We've learned so much, and I wish we could have you teach everybody how to do this. And thank you to the audience. It's been, hopefully you've enjoyed it, you've learned some things, and there are other resources available that the company will send you. So with that, we're going to wrap this up. It's been a great hour. And everybody have a fantastic evening or an afternoon. Thanks to everybody.